Hi, everyone. Here we go again. This morning we were talking about one disease in which there was a multidisciplinary approach applied many years ago, which have shown the results. Now we are discussing a different disease, which is much, much more common than cystic fibrosis, have much more morbidity and healthcare costs than cystic fibrosis. It's worldwide, but unfortunately we have so far not been able to apply a more comprehensive multidisciplinary approach to handle this disease, and the outcomes are a little different. Now, I still don't have any conflict of interest. Nothing have changed in the last 2 hours. Asthma, that's what we are talking about today. It is a chronic inflammatory disease like rheumatoid arthritis or a number of other similar diseases. It has distinct clinical hallmarks, which means that there is a partial or complete reversibility of the airflow limitation on lung functions. There is a bronchial hyperreactivity in response to a certain allergens, which differ from person to person. And it presents with reversible respiratory symptoms, which are usually wheezing, shortness of breath, chest tightness, and so on. But the symptoms are not persistent. They come and go. But when they are there, they can have a significant morbidity and even mortality. Number of inflammatory markers are involved. Without going into too much detail, most common cells which are involved are the mast cells, T lymphocytes, and eosinophils, and they produce a number of cytokines and mediators which have their distinct effect, which eventually lead to the specific Th2 modified inflammation, which had a bronchial hyperresponsiveness. So the treating underlying inflammation is a key part of treating asthma. So albuterol alone will not gonna do the job. Now, inflammation is quite complex, but few markers is that airway lumen is narrowed because of the epithelial damage and smooth muscle hypertrophy. Inflammatory cell infiltration leads to the vascular dilatation and the increased fluid in the airways. Goblet cell hyperplasia, increased mucus secretion, thickened basement membrane, increased mucus, and so on and so on. But the bottom line is that with all those inflammatory changes, the size of the lumen, airway lumen is decreased, air movement is affected, and with that inflammation, the ability to breathe is affected. Now, this is much more common than cystic fibrosis. In US alone, there are about 17 million patients with asthma. And in spite of having adequate treatments, still almost 5,000 people die from asthma every year. And this is only in the United States. And almost all of those deaths are preventable. Asthma-related hospitalization is about 500,000 every year. Emergency room visits are about 2 million every year. And healthcare cost is somewhere between 11 to 15 billion dollars a year. And about 3 million work days lost every year. And this is only United States, which reflect about 20% of the total global healthcare cost of asthma. Now, if we briefly look at the demographics, about 2/3 are adults, about 1/3 are children, about 1/3 are intermittent asthma, about 2/3 is persistent asthma. Persistent asthma is something on which you need daily asthma medications to prevent. Intermittent asthma means that all you need is albuterol. How you differentiate between the two, I'll come to that in a minute. Its prevalence is different in different ethnic populations. In Caucasians, it's about 5 to 6%. In African American, it's about 7 to 8%. And in Hispanic population, depending upon the heritage, it can be anywhere from 4 to 12%, which means that the Hispanic population, if you subdivide it, the Mexican Americans have a very different percentage of asthmatics compared to Puerto Ricans. So this is just an averages which are mentioned here. Similarly, about 45% of asthmatics are male, about 55% are female. In pediatrics, this ratio is reversed. but after the teenagers and age, there are more women which are with the recent diagnosis of asthma compared to the male. Now, having said that, in spite of being 2/3 of the asthmatics being adults, still, if you look at the demographics or the statistics, about 70% of the asthmatics do present with their symptoms by the time they are 3 years of age. So most of the asthma is still not only pediatric, but infantile asthma, which progress into a long-term chronic illness. And only 30% of the asthmatics start having their symptoms after 3 years of age. So it starts very early in life. But as we all know that the wheezing in early in life, not all wheezers become asthmatics. There are a number of other reasons of wheezing at this age group. There can be structural anomalies of the airways, vascular rings, and so on, prenatal and postnatal exposure to maternal smoking, which leads to the smaller lungs at birth and increased risk of wheezing with any kind of respiratory infections, which can be RSV, pertussis, rhino, and list goes on. Gastric reflux-induced bronchospasm is still an entity. Kids who are born premature are at an increased risk of wheezing. Kids with the other respiratory diseases like cystic fibrosis is a risk factor, and the male gender by itself is an increased risk of wheezing because of the relatively immature lungs in the males at birth compared to the females. So the lungs and brain usually grow in the same proportion. All right. Now, but there are a number of factors which do predict that certain wheezers are at an increased risk of asthma as they grow older. And those things are a family history of asthma, which is usually more with the maternal than paternal. And I'd like to mention it's the family history of asthma, not the allergy. If there's a family history of allergy, that's not a risk factor for asthma in children. But if there is a history of asthma in the parents, that is a risk factor for the asthma in children. Similarly, early atopic disease, positive skin tests, eczema, rhinitis in the children do increase the risk of asthma. Allergen exposures, dust mite animals, and so on, viral infections, exposure to smoking, and those all increase the risk of developing asthma as the kids grow older. Similarly, those who have more severe wheezing or disease in the early first 2-3 years of life are also at an increased risk of developing asthma as they grow older. Why is it important to diagnose it early or treat it early? Because the studies have shown that the increased morbidity from asthma is in the kids less than 5 years of age, as one of the studies have shown that in kids who are less than 5 years of age, there is an increased hospitalization compared to the older children. So the younger the children is, more is the presentation, more severe the disease is, more of hospitalization and more morbidity. So that's why it's important to diagnose this early and treat it early to avoid the morbidity. Now, there are a number of studies with the long-term cohorts are being done. I'm just mentioning the results of one of them. This was from Hellbach's study a long time ago, and not that long, but still, it's still considered as a hallmark of the infantile asthma or infantile cough and wheezing phenotypes. This was a 2-hour study in which they took about, I think, 3,000 or 4,000 children at birth and followed them for 6 to 8 years. They are still following them. Those kids are now 20 to 30 years old. And what they found out was that in kids who wheeze, about 50% of them wheeze during the first 6 years of life. And among those who wheezed, they can be easily separated in 3 different subgroups. One of the groups which they called was the transient wheezers, who wheeze very early in life, but then by the time they are 3 years of age, the wheezing is almost gone. Second one was the non-atopic wheezers. In them, The wheezing started at around 2-3 years of age, and then as they grow older, it decreases with the incidence, and eventually they became wheezing free. The third group were late wheezers, or the IgE-associated wheezers, in which the wheezing started very late. That is the group who started having symptoms at around 6 years of age, and then they went on to develop a garden variety asthma phenotype. Now, if you subdivide them based on what their risk factors were, in transient wheezers who had wheezing during the first 3 years of age but stopped wheezing by the time they were 6 years old, they had low lung functions at birth. They were exposed to maternal smoking. As they grow older, their lungs become more stronger, and they were able to not to wheeze with exposure to viral infections and so on. And those were the kids who eventually did not develop asthma, and their lung functions became normal as the lungs grew. Second group was the kids who were wheezing at 3 years of age but continued to wheeze at 6 years of age, and they were the one which were called persistent wheezers. Those were the kids who have early exposures to the atopic disease. Either they have allergic rhinitis, or they have eczema, or both. They have high IgE levels. Some of them also had exposure to smoking, and some were also male. So, which means that with the early exposure to atopic exposures and the allergic phenotype, these kids continue to have wheezing and eventually will develop asthma. The late wheezers are the ones who had no wheezing during the first few years, but by the time they're 6 years of age, they were wheezers, and they were the kids, just like the persistent wheezers, were atopic and had a allergic phenotype, and most of them were male. So these can easily divide them into 3 different groups of the wheezers. Among them, transient wheezers are the ones which usually do not develop asthma, which is about 1/3 of the total. But you have to figure out who are these 2 groups early in life so that you can treat them aggressively, so that you can control their clinical symptoms to an extent that they don't develop in hospital admissions or asthma phenotypes. That led to different groups looking at different statistical models to differentiate between different subgroups of wheezers in infancy to find out which among them are at a risk of developing asthma. And eventually, the most commonly accepted phenotype is the Rodriguez study, in which they mention that if someone have more than 3 episodes of wheezing within the last 1 year, with at least one of them is diagnosed by physician, not all by the parents, at least one of them by physician, but at least 3 episodes of wheezing, and either they have 1 major criteria or they have 2 of these minor criteria, they are about 9 times more at risk of developing asthma as they grow older. So these kids with recurrent cough and wheezing, if they have a family history of asthma, if they have atopic dermatitis or eczema, or if they are sensitized to allergens early, they are at increased risk of developing asthma, and these are the kids who need to be treated aggressively very early in life. Or if they have wheezing without colds, or have high eosinophil levels, or allergic sensitizations, and so on. So some of the allergic sensitizations, and for that you need to do a blood test or the skin testing. But even without doing that, those kids who have recurrent wheezing and have family history of asthma, or they also have eczema or allergic rhinitis, those are the kids who are at an increased risk of developing asthma as they grow older. So their wheezing should not be taken lightly, and they should be isolated early, treated early, so that they can have less chance of developing increased morbidity. Why that is important? These are the 2 studies, one in adult and one in children. And on one axis is the duration of symptoms in years, and the second axis is the degree of the lung functions which are reversible, which shows that the longer these patients are not treated, their drop in lung functions become irreversible. Means they develop permanent changes in their lungs, so that when they grow older, no matter what you do, they will continue to have the problems, and they will be at a risk of having more severe asthma symptoms throughout their life. There are also some studies which suggest that this might be a subgroup who, as they grow older, will be at an increased risk of developing COPD or other chronic lung problems as they grow older and may need oxygen early in life. And this is not only pediatric. This is a pediatric study which shows if duration of symptoms is less than 2 years, there is a maximum improvement in the lung functions with the treatment. But as the duration of the symptom increases, the improvement in lung functions becomes less and less. Similarly, in adults, if the duration of symptoms is less than a year, you can have a good improvement in peak flow after treatment. But more the duration of untreated asthma, the less is the response to the therapy. And that is also shown by a number of other studies. This is a very famous Australian study by Oswald, in which they took a few thousand kids at age of 7 years, diagnosed them with gave them a number of diagnoses depending upon whatever they were diagnosed by their primary care before that. Either someone was called wheezy bronchitis, someone had a mild wheezing bronchitis, someone was called asthma, someone was called severe asthma, and some were the controls. And they followed them for 35 years. And what they showed was that the patient who had difficult to control symptoms or who were labeled as severe asthmatics were the ones who had lung functions or FEV1 around 80% of the normal. And those were the patients, no matter what treatment they received for the rest of their life, their improvement in lung functions was not there. They continued to have low lung functions, whereas all the other kids who had normal lung functions, with the treatment, there were no significant loss of the lung functions, which suggests that if the lung functions is lost during the first few years of life, that change can be permanent. So that's why it's very important to treat those kids early so that they don't develop airway remodeling and eventual permanent loss of the lung functions. Now, how you define which of those kids or which of those wheezers need the treatment or which need to be on a daily asthma medication? There are asthma guidelines, can be about 600-700 pages, but without going into detail, a very simple rule of 2, which you can easily follow. If someone having a daytime symptoms of cough or wheezing more than 2 days a week, or nighttime symptoms more than 2 nights a month, or takes albuterol for his symptoms more than 2 times a week, or uses 2 containers of albuterol in a year, that patient by definition is a persistent asthmatic and need to be on daily preventive asthma medication. Anyone less than that is the intermittent asthmatics for which albuterol alone is enough. And that will be about a quarter of the patients with the asthma. But a 2/3 of them will still need daily asthma medication. And if someone doesn't have to fit all those 4 criteria, if any one of those are there, the patient is a persistent asthmatic requiring daily asthma medication. Now, which medications and how? It depends on the severity and frequency of the symptoms. You can have when you have a more persistent asthma, you can have a mild, moderate, severe persistent asthma, and therapy escalate according to how frequent the symptoms are, and then it goes down to how good the control is. And then once you have achieved the control, then the therapy depends on how to maintain that control. Then the severity becomes irrelevant. For example, if someone who is mild intermittent asthmatic, which means daytime albuterol less than 2 times a week, nighttime symptoms less than 2 nights a month, need of albuterol less than 2 times a week, or not using more than 2 inhalers in a year, those are the ones with intermittent asthma. They do not need a daily asthma medication. On the other hand, Anyone more than that, it is a mild persistent. The preferred medication is low-dose inhaled corticosteroids. Alternative can be leukotriene receptor antagonist like Singulair and so on. But the preferred medicine is still inhaled steroids. If the symptoms are not controlled, either you can double the dose of inhaled steroids or add a long-acting beta-2 agonist combination medication. And even then, if the symptoms are not controlled, increase the dose of the combination medication. You can always add leukotriene receptor antagonist at top of any other medication too. Now, why is the inhaled corticosteroid the preferred medication? Because this medicine, this group of medicine is the only group which have demonstrated that they can be not only disease modifying, but they can prevent death from asthma. And why is that? This is a Canadian study. It was done about 15 years ago, and the data was drawn from the Canadian National Healthcare database, which had about, I think, 4 or 5 million patients. And what they showed was that if you plot number of canisters which were filled from the pharmacy in a year and plot it against the ratio of the death from asthma, the less the prescription was filled, the more higher was the risk of dying from asthma. And the more the medication was filled and used, the less was the risk of dying from asthma. So the more adherent you were with the therapy, the less was the chance that you will die from asthma. So that's why it is a preferred medication. And another study have shown that compared to placebo, Singulair can improve the lung functions about 8 to 10%. Inhaled corticosteroids improve it by about 14 to 50%. But the question comes up, how much is enough? Because inhaled steroids come in different doses, and you cannot keep on escalating the dose if the symptoms are not controlled, because this is a group of medication that up to a certain level, it do improve the symptoms, but after that, there is a plateau. After that, no matter how much you increase the dose, all you will be getting is the increased risk of side effects. And that's why the guideline says that most of the patients will have an adequate therapeutic response at or below 400 micrograms per day, irrespective of what the inhaled steroid is. Now, this is a study comparing the 3 different doses of fluticasone, which is Flovent, compared to placebo. FEV1, that's lung function parameter, compared to placebo. The 100 micrograms of fluticasone had an adequately better or significantly better improvement in lung functions. But when 100 milligrams were compared to 200 milligrams or 500 milligrams of the same medications, there was no additional benefit. All 3 doses were able to produce an adequate response, which means after this level, if your patient is still not having an adequate symptom control, you go to the combination medication instead of keep on increasing the dose of the inhaled steroid. And this is the same effect seen in budesonide compared to placebo, 400 micrograms twice a day and 800 micrograms twice a day. Both were equally good, but no, they were not significantly different from each other, which means that that is the plateau. Similarly, triamcinolone, compared to placebo, 200 milligrams had a significantly better peak flow, 400 milligrams had even better, but from 400 to 1600, there was no additional benefit. Now, another study, Lovelets, in this study, the patients who were not controlled on inhaled corticosteroids, they added Singulair or leukotriene receptor antagonist, and they found out that the asthma exacerbations were 25% decreased when the second medication was added, which was a positive add-on response. Similarly, in another study, they either doubled the dose of inhaled steroids or added the combination medication. This was a Flovent, and this is Advair, I think, salmeterol and high dose of beclomethasone, and this is with the salmeterol. And doubling the dose had some improvement in lung functions, but changing it to combination have much better response than the doubling the dose, which means that instead of increasing the dose of inhaled steroids, it's always good to add a combination medications to it. So there are medications which can have adequate control of asthma, which are there for last 15 years, which can have a good asthma symptom control. Guidelines have shown that they are very effective, but still more than 5,000 people die from asthma every year. Still 500,000 go to the hospital for admission. Still 2 million go to the emergency room every year. And still $15 billion are being spent every year. Why? Because we have not developed a comprehensive way to treat this as a disease as we have done with the cystic fibrosis. There's no communications involving the families in the care or having it coordinated at a primary care level. So that is what is needed, more education and more trust of the family so that the adherence can be maintained, because the most common cause of dying from asthma or having an acute asthma is not taking the medicine. And this is another study which was done in Australia, in which they looked at the people who died from asthma in one county over the 2 to 3 year period. And then they looked back to see what their severity of asthma was. This was asthma deaths. And they found out that the number of patients who died from severe asthma was no different than the number of patients whose asthma was diagnosed as mild. So it's not that the severe asthma is at an increased risk of death. Any kind of asthmatic is at an increased risk of death if they are not adherent with their medication. And sometimes, no matter what you do, you still can't have a good asthma control. And that's when you have to go back to basics, and let's hope this works. And I just want to show you what is usually needed in those cases.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
Let's go back to the beginning. And then we will do this. There we go.
All right.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
And I rest my case. All right, I hope I can get out of here. I think it's somehow a little locked. Can we? All right. Just as we go to the next slide. Yeah, we can get out of here. This one. Yeah. All right. I think I stop here. Any questions? Thank you.